name's Dr. Stephen Beecher, and I have the pleasure of just talking today with my mentor and now colleague, Dr. Thomas DeCoster. Dr. DeCoster originally went to medical school in Missouri, and he did his orthopedic residency in Vermont, followed with sports medicine and trauma fellowship in Iowa. He did an AO fellowship with Dr. Gratz, as well as in his later years, he did a fellowship with Turnell on acetabular fracture surgery and an Oxford sabbatical for the Lizaroff training. He is very well published, just putting his name in the PubMed. I've read many of his articles over the years, but he's got over 70 publications. He has trained countless residents and fellows, and I had the pleasure of spending a year with him in Albuquerque. And I'll just say briefly, Albuquerque was very memorable, and Dr. DeCoster was a large part of that very influential year on my life and career. So thanks for talking with me, Tom, and thank you to the AO for giving me this opportunity.
Yeah, thank you, Steve, for doing this, and to AO for the idea, and then for setting up the mechanics of this discussion.
So I guess we'll start with the AO itself. What role do you think the AO played in your career?
Yeah, the AO played a very positive and important role in my career, which started back in the 1980s. AO predated the OTA, so it was an organization that was interested in promoting trauma care and internal fixation. And it was international. It extended beyond US borders. They were very much involved in education, which is a key point. I think without their educational efforts, internal fixation would have failed because people would have just read about it, tried it, used poor technique, and then blamed it and said it wouldn't work. It reminds me, after World War II, the military found Kuncher's work, and they decided to bring that back to the US, and they sent it to 3 different places, Vanderbilt, Johns Hopkins, and somewhere in Boston, to do intramedullary nailing, which was a new concept. But they couldn't make it work. They failed. They all got infected, and they said, this doesn't work. This is baloney. And it took 25 years for somebody to do it right, to make intramedullary nailing, which is one of the great advances in orthopedics of the last century. They tried it and it failed, but they didn't use the right technique. So to me, that's a key component that AO recognized and implemented. And that was one of the key things that happened over the course of my career since the 80s. Initially, internal fixation was not accepted treatment for almost anything. Non-operative treatment and cast treatment and traction was the treatment of fractures. And any kind of internal fixation, you had to justify it tremendously. And a 10% infection rate just ruined you. And so AO was very important in bringing internal fixation to an acceptable level of expertise among the practitioners, and then promoting it worldwide. And now that's become the standard treatment for most fractures.
When in your career did you get involved with them?
You know, my first involvement with them was doing a basic course as a resident. And so that's another great thing. They start early in the educational process, so you learn going along. And then advanced course, and then you get to know some of the faculty. You put a name with a face, or face with a name when you're reading articles. You know kind of what they're working on. And then that led to AO fellowship, which was a 2-month experience. It was originally scheduled for residency. For me, this is another great lesson, is you got to be persistent. We had some issues. I got the approval of the chairman to do this fellowship as a resident, But then one of the faculty left, and they were short, and they convinced me to postpone it for a year. So when I did fellowship, I was going to do the AO fellowship for 2 months. They said, "Oh yes, we support that idea." But then when time came to do it, they wanted you to be there and work. And so it's like, well, can't you delay it for another year? So I delayed it for another year. Then when I took a job, I said, well, I've got this AO fellowship I want to do. They said almost exactly the same things. Oh, we support that concept. And I said, well, can you put that in writing? And some places were reluctant to do that. The place I ended up choosing, University of New Mexico, was willing to do that. And then sure enough, a month before I'm set to head to Europe, to go to Graz, Austria with Dr. Rudy Siskowitz and Munich for a month each. Well, one of the faculty left and they were like, "Can't you postpone this for a year?" And I said, "No, we have a deal. You said I could do this. I'm not, you can solve that problem some other way." And sure enough, they figured out another way to do it. They just take the path of least resistance. And if you keep saying yes all the time, then you become the default value. So you can't say no all the time, but it's important to say no some of the time when it's in your interest. But the AO fellowships were a great way to get credibility, expertise, networking, and I highly recommend that, especially to a English-speaking foreign country. I think that's the best place to go. The same is true for sabbatical. I remember being in Munich. I couldn't order a loaf of bread. I didn't know how. I didn't really speak German, but I could nail a femur because anatomy is the same, and most anatomy words are Latin-based. So the gluteus maximus is the same in German as it is in English. It's Latin. So the anatomy you can still do. So I was, you can function at one level, like nailing a femur, but you can't hail a taxi or do other things. It was an interesting dichotomy there.
Looking back on your career, is there anything that you would have changed about your career if you had a second chance to do it all over?
Not really. I'm happy with what I chose. When I first came out, I think I had a choice between going somewhere famous and being, a big place and being the junior guy to a famous person, or go someplace less famous and kind of be your own captain of the trauma ship. I think either way can work. I had a good experience coming to a relatively unknown place. I think there were 4 hand surgeons, mostly retired military, and me was faculty back in '86 here. And we've grown to 35 faculty and a functioning division of orthopedic trauma. And so this place offered 2 great opportunities. One was the initial opportunity to do lots of cases and to bring the capabilities that I had, like I knew how to do an intramedullary nail of the femur. That was something that was not really being done frequently in this state prior to that. And then the second thing is I kind of recommend a rolling 5-year plan. So my plan was to stay here 5 years, do a bunch of cases, get my own clinical experience, and then go to a bigger, more famous, more productive place. But this place kind of turned out the weather here is actually quite good. It's not the heat of Arizona. It's a pleasant place climate-wise, far better than what I expected. But professionally too, the department grew. We had 10 faculty. When I was at Iowa, Buckwalter, who became the chairman, they talked about him as being a PGY 17. And so there was this hierarchy that was pretty well present. Not quite the U.S. Senate, but seniority mattered a lot based on your opinion. And it took a lot of years to build up that. So after 10 years here, I think I was the most or second most senior person out of 12 faculty, whereas if I had stayed at Iowa, I would have been the 22nd most senior faculty out of 25. And it takes a long way to get to the top if you've got that many people ahead of you. So there's advantages and disadvantages. You're kind of on your own, so you're wondering if you're doing the right stuff. Research is harder. At Iowa or other places where people are doing research, it's easier to tag on and add on and then develop your own way. Whereas when you don't have other people doing it, it's hard to build the canoe to get across the river. If the boat's already there or the road's already built, it's easier to get there.
Who would you say your most influential mentor was and why?
Yeah, initially, Dr. Seligson was the trauma guy at Vermont, and he got me interested in trauma. Dr. Freimoyer was the chairman, and he got me interested in academics. And then when I came here at New Mexico, Dr. Ulmer was the chairman, gave me a job. He was the president of AOA. Got me involved in national orthopedics a little bit. So those are some of my best professional mentors.
Looking back, do you think what do you think makes a good orthopedist at the beginning of your career now, or is it the same? It's the same set of qualities and it hasn't changed over time?
Well, yeah, it does change. Initially, you need enthusiasm. That's number one. You need ability, affability, availability. But to me, the most important thing is enthusiasm. You have to be willing to work long hours, apply yourself, think through things, listen to people, take the good with the bad, or throw out the bad and keep the good, whatever. And then as you get older, it's perseverance, because trauma used to be and still is to some degree a young man's game. But back in the 80s, there were almost no older orthopedists. Dana Mears was a big trauma guy at Pittsburgh, but after 10 years, he went into doing total hips and didn't do pelvic fractures anymore. And that was the routine. In fact, most academic places, they would have a trauma guy for 5 years. He wouldn't publish anything. He wouldn't get promoted. So he'd leave and they'd hire a new guy. So they were always underpaying them. There was no career longevity. You just did trauma for 5 or 10 years, and then you moved on to some other subspecialty where you could actually have a career and make money. But now trauma offers that opportunity. But it does require perseverance, because it is a demanding career, time and effort. And one of the other pre-questions you talked about is balancing your lifestyle for career. So I have an article in JBJS on this, and what I did and what I recommend to people is look at life as an orthopedic traumatologist as a three-legged stool to support you. One is your clinical work, one is your family, and then I think you need a third, something else, and you can pick whatever that is. For me, it turned into golf. I thought golf was just a total waste of time. It took too long, and it was Republicans with plaid pants, and I had no interest in it. But I had a senior partner that got me to play, and I got my wife started on it, and she's the multi-time club champion. So she went from never playing to playing all the time. But it doesn't have to be golf, but something, fly fishing, photography, just some other thing. And you can be a little bit selfish. Golf to me complemented the family. The kids, I have two kids, Evan and Mallory, that have done great. But golf was an important part of them growing up. They both played high school golf. Evan played, well, they both played in college to some degree. And we've shared lots of great golf experiences going to Scotland and other things. So sometimes the golf can kind of supplement the family life, but it doesn't have to. You also, in my mind, it's okay to be selfish. There are times when I just went to the golf course to get away from the patients and the OR nurse and my secretary and my wife and my kids, and it was just me time out on a green grass with a curling 40-foot putt. I think that provides some degree of balance in life. And so that's what I recommend, is devote about a third of your time to each effort.
Looking back, what's a bad complication that you can recall?
Yeah, complications absolutely happen, and you need to learn from them, but don't let them scuttle you. I remember in M&M's in general surgery when I was an intern, there was an old crusty general surgeon that was famous for, he diagnosed a ruptured aneurysm over the phone, met the guy in the lobby, took him up in the elevator and had opened him up in the elevator and had his hand on the bleeding aorta by the time they got to the OR. But anyhow, there was this case, just one thing led to the next. It was clear it was going to end up in death. And at the end, they said, well, what did you learn from this case? And he said, I've never seen this complication before, and I'm going to forget this case by sundown. So there's some cases that are just so bad, you've got to put them away and not let them paralyze you. But in general, you want to try to learn from complications and from problems. You probably learn more from a case that goes bad than a case that goes perfectly. But one thing I remember was there was a guy with a complicated open proximal femur subtroch with intertroch extension, fairly young guy. He ended up with 8 operations, healed, some deformity, some issues, but generally great outcome. We took, then at like a year and a half, we took out the nail, and he got a fat embolization syndrome from that, taking out the nail, and almost died. Ended up with significant residual problems. So it's like, oh my God, after all this, the innocuous thing turned bad. So that was a hard one to think back on. And there are going to be patients that you either can't help or that you hurt. And that's the nature of the beast of trauma surgery. And so you've got to be able to deal with those mentally and move on somehow. But it also, I mean, I have an article on removing intramedullary implants. So it at least stimulated an interest, and that also gets quoted quite often. And one of the points of it is there's a variety of problems associated with removing implants. Everybody thinks it's easy. Nobody looks good taking them out, and sometimes it's a big problem.
You cut, you cry.
Yep.
What do you think over your career has changed? I know that you said when you started, there was a lot more non-operative, but just over your career, the operative treatment of orthopedic trauma, what do you feel has been the biggest advance or the biggest change?
Yeah, well, in general, the biggest advance is the acceptance of operative treatment and the recognition that it does provide better outcomes and the ability to do it. So we weren't as good, plating a radius and ulna. It's done better now. We have more experience. We've done hundreds of them instead of a few. Volar lock plating is a far better treatment for distal radius fractures than pins and plaster or X-Fix. So a variety of things have gotten better. Some through concept like volar lock plating, but more generally through more people having the ability to do them. If there's only 10 people in the country doing femoral nails, a lot of the femoral nails that get done aren't going to be very good. Back in the 90s, there was 10 people in the country doing acetabular fractures with enough volume to really be good at it. Now there's hundreds of people doing the same kind of operations, maybe a little more percutaneous and a little less dissection. But to me, the fact that there's more people doing more of them is what's made the outcomes better. And to that same extent, the trauma was sort of the Cinderella subspecialty of orthopedics. Like I mentioned, people did it for 5 or 10 years and then went on to something else, their real career in some other orthopedic subspecialty. And I think the fact that now people stick with trauma and do it for 30 years instead of 5 or 10 years, that's been a tremendous advance. And you don't have to be the first person to do that. There would be others who have done that. That's more the expectation of the chairman or the hospital administrator or whomever. So that makes it easier to do that. So I would say in general over my career, it's been the acceptance and the improvement in techniques and implants of internal fixation of fractures. And the manner in which we do it. You don't have to operate at midnight or 2 a.m. I mean, my first 10 years, there were lots of 20-hour surgical sessions, and that's just not necessary and not optimal either for the patient or the long-term health of the surgeons. So the trauma rooms and the trauma service and rolling stuff till morning and doing it at 8 o'clock in the next day instead of rolling it to the next day and doing it at 10 o'clock at night the next day. There was no point to that. So I think the manner in which cases get done is also a significant improvement. The nature of call. Call is now just sort of a caretaker situation. You're there in name only, but you don't have to go in very often. You don't do much at night. You wrap them up and set them up for the next day or triage them. And I think that's a better system in general.
When did you go to France with Letournel or Canada?
Yeah, that was about, I don't remember the years. He was quite the character, very flamboyant. He had everything set up. He was a stickler for operative technique and sterility. For example, no light handles because the lights were outside of the surgical sterile field, and you couldn't move your hands above your armpits. And so that also required the nurse, the circulating nurse, to be paying attention. They would have to adjust the lights constantly to keep them, the surgical field illuminated. And instead of heading to the hideout or having coffee or telling jokes with the anesthetist, the circulating nurse was an integral component to the operating team. So I learned all kind of things from him, especially the ilioinguinal approach, and watching somebody do that 4 or 5 times that had done it, 1,000 times. I think that got me over the hump to being proficient at the ilioinguinal approach, which is, especially the middle window, is not a standard orthopedic thing. You're dealing with a vein that can bleed tremendously, and you've got the corona mortis, and you've got to deal with issues that aren't part of standard orthopedics. So I think that really helped me a lot, building confidence, watching somebody who was a master at it.
Is there anything you did to be a better mentor? Is there any education theory or any mentoring coaching that you did, or anything you did to become a better mentor to others?
Yeah, I took the orthopedic educator course, which was Frank Lippert, and I can't remember this other guy. That was something Omer recommended. It was a little bit odd, but it was quite worthwhile. So it was a week-long kind of retreat in Illinois at this almost a monastery type place. This was before cell phones, but you didn't have a regular phone even there. And they talk about teaching the teachers and being involved in identifying the really important things from the kind of important things, from the interesting but not important things, from the things that aren't true that get taught. I mean, so there's sort of a little bit of a week-long course in educational theory. I think they do it in Chicago now, but that's one thing I'd recommend. I also got involved in the ABOS as an oral examiner, and that allowed me to see cases of people. They present 10 or 12 cases, and you review 3 or 4 of them, and you go over 20 people's cases, and it's kind of an eye-opener. The kinds of things people are doing, good and bad. Some people are outstanding, and some are unbelievably the other way. But to me, that helped realizing what, all these people had done an orthopedic residency, and then this is what they're doing in practice, and these are the mistakes they're making, or these are the problems that they're having. I think that gave me an exposure to try to help teach residents, and especially fellows who are very close then to a board exam practice evaluation situation. So that's 2 things I'd recommend: is orthopedic educators course put on by the Academy, and getting involved. It doesn't have to be the ABOS, but some kind of a situation where you're reviewing cases done by other people in a critical manner without, you don't have to spend a huge amount of time, but you kind of have your finger on the pulse of what's going on.
All right, Dr. DeCoster, thank you so much for everything you've done for me, and I hope the AO can pare this down and use 20 to 30 minutes of our hour-long conversation. But know that from one fellow at least, you've been very appreciative and very.
Yeah, very much. Thank you, and thanks to the AO for the idea and for practically organizing this.
All right. See you, Tom.
Great, thanks.